name is Dr. Jason. I am from the National Cancer Society Malaysia. I work as the operations lead as well as a public health doctor in this NCSM. NCSM is an NGO, non-profit organization. Since 1966 until now, we were founded by the first clinical oncologist in Malaysia, and we are focusing on care, which is screening, education, as well as support. And today is no different. Today, we have our program called the SKD series, where we take the cancer of the month at the end of each month to talk about various cancers. And today is no different because April is Nasopharyngeal Cancer Awareness Month. And today we have a very interesting speaker for us today. Dr. Teh Hui Mon currently serves as the Otorhinolaryngologist and ENT Surgeon in Hospital Tengku, Ampuan, Afzan, which is in Kuantan. She obtained her medical degree from University Putra, Malaysia, and completed her specialty training under University Malaya. She is also a member of the Royal College of Surgeons, Edinburgh, MRCS ENT. After graduating as an ENT surgeon, Dr. Teh served as head of department in a remote district hospital in Sabah for 2.5 years. Despite the struggles and limitations of resources in the rural area, she managed to set up the ENT service in Hospital Keningau, Sabah, and serve the rural community in Sabah. She believes everyone at every corner of the world deserves optimal medical treatment. Hence, she's also active in organizing and participating in many health community services throughout her medical journey. Currently, she's back in Semenanjung, a little hometown in Kuantan, and she's now providing surgical care for general ear, nose, throat, and neck conditions, with her special interest in ear disease, head and neck tumor, and airway problems. In the quest of excellence for her field, her passion drives her to organize multiple local international ENT events. She also recently chaired the ENT Summit 2024 to gather great minds from all over the world, dedicating to share the latest technology and surgical techniques and to advance ENT healthcare paradigm in Malaysia. She is born and bred as true Malaysian. She can converse English, Bahasa, Mandarin, as well as Cantonese. She enjoys interacting with children. Her passion in airway surgery has given her great interest in airway-related activities. Therefore, she is an international certified yoga instructor, paddy rescue diver, as well as Mykonos free diver. So without further ado, Dr. Teh Hui Mon, take it away.
Thanks for the kind introduction. So today I'm going to share a bit of nasopharyngeal carcinoma. So I'm going to share the slides now. Let me check. Give me a minute. Okay. All right. So why are we talking about nasopharyngeal carcinoma today? So nasopharyngeal carcinoma is not to say it's rare in our society. It's very common. And I'd like to do my disclaimer. I have nothing to disclose and I have no conflict of interest in this presentation. So for my reference, there is one of our KKM printed guideline, which is the management of nasopharyngeal carcinoma, which has been published. You can go to our KKM website to download it, or you can scan this QR code for your guide. So there's another book which has been launched in 2020, written by our own local lecturers from USM, which is called the Evidence-Based Approach to the Management of Nasopharyngeal Cancer. So this is a book which tell you a lot details about nasopharyngeal cancer. If you're interested, you can get a copy online. And why are we talking about NPC today? So we know that our Malaysia hero, Lee Chong Wei, our national badminton player, he suffered from NPC. Why? Because NPC is the fourth most common cancer, and the NPC is predominant among the Chinese, followed by natives of Sabah and Sarawak, especially the Bidayu and Malay. So even in Sabah, I can see that's a lot of our patients from the ethnic of Kadazan, Dusun and as well as Murud. So if you see this kind of patient with very proliferative neck masses and ulcerative neck mass, the first things that come to your mind is not infection. So it's supposed to be something cancerous in the body which presented with a neck metastasis. So looking at this anatomy of the picture, you see that nasopharynx is actually covering at the back of the nose. So it is quite hidden. That's why today our topics is unveil the tumor behind the nose. So the only way that we can diagnose and looking through details into to diagnose it is through the nasoendoscope. So this is the MRI that's showing there's a mass over here. I hope you can see my pointer. Okay. So this is the nasopharynx mass behind the nose, and this is the endoscopic view. I'll show a little bit more later in my slide. So looking at the surgical anatomy of the nasopharynx, so we can see this is the nasal cavity. Let me check on the pointer. Okay, so this is the nasal cavity, and the nasopharynx is hidden behind the nasal cavity. There's no way that we can diagnose the T1 tumors for the patient. So that's the only way is you should refer this case to the ENT surgeons to do a scope and look behind the nose. So it is hidden behind here, and there's a lot of structures which involve in this nasopharynx. So you could see this one is the sphenoid sinus. This is the brain. This is the brainstem and clivus and the vertebral, cervical vertebral, and this is the nasal cavity. And this is a hard palate and soft palate. And not forget, there's a eustachian tube that connect into the middle ear. So looking at the cross-sectionals of the axial view of the anatomy, so this is the nasopharynx, and we could see there's a lot of muscles that which is nearby. So this is the parapharyngeal space, which we have a lot of muscles that involve in mastication, chewing, and as well as the prevertebral muscles at the back, and the major vessels, which is the internal carotid artery and as well as internal jugular vein. So when the tumor spreads laterally, so these are the muscles which can involve and give us a lot of symptoms, and as well as it can easily spread through the foramens and also the weak points over this area. So what is the clinical presentations and it should it actually ring us a bell in our head that we need to refer these kind of patients to the ENT surgeons. So if you have a patient with a painless neck lump, not talking about the painful neck lump like the neck abscess, if you have been tried with a course of antibiotic for 1 week and it doesn't shrink, please refer to us. And also, 80% of the patients has very subtle symptoms like a bloodstained nasal discharge or saliva. And most of the time in Malaysians, they will say, oh, it's just because of the wet weather, the heaty weather, and they get a bit of heat in their body and they get epistaxis. So which doesn't actually bring most of them to the GPs or the ENT surgeons to have a check. So we should not miss this kind of patient. If they present with these symptoms, I will advise them to at least refer to ENT surgeons to get a look behind the nose. And not forget about the unilateral ear blocks and hearing loss. I will describe why this kind of patients is also one of the common presentations in the nasopharyngeal cancer patient. And headache, because the spreads of the tumor and the erosions of the bones and the muscles and adjacent nerves that can give the patient's headache. and as well as facial numbness and diplopia. So this is the pictures that showing the patients has a level 2 and 3 cervical lymph nodes. When you palpate the lymph nodes, it is hard in consistency and it's not mobile and it's not painful. Please remember the patient could have a risk that getting this NPC. Okay, this is a wrong way to how you ask your patient to stop the nasal breathing, nasal epistaxis. So you should bring the head forward. But if you have a patient with a persistent epistaxis, please do not hesitate to refer to the ENT to have a scope to be done. So most of the time that this kind of patient present to us with a late presentation because when they have neck mass, which has already, the tumor has been metastasized into the cervical lymph nodes. So, and nasal congestions, which is in very small numbers that bring them in, epistaxis, the nose bleeding, and also post-nasal drip. Diplopia is also one of the reasons, and we get a lot of referrals from the ophthalm and also medical. Deafness and tinnitus is also very subtle. Not everyone with a single-sided deafness will come to you so soon. I will explain why, how they can actually present these kind of symptoms. So for the ear, why they present with a unilateral hearing loss? Because they have effusion. Why? Because the tumor behind the nose, which is in the nasopharynx, it can actually occlude into the eustachian tube here. So the eustachian tube is function as a drainage from the middle ear mucus and also fluids that going into the nasopharynx. When there's a tumor which block this area, you're presented with a middle ear effusion. So when you do an otoscope, when the patient present with unilateral hearing loss, you could see these fluid levels and also bubble signs in the middle ear. So this kind of patient, do not treat yourself. You can refer to ENT. We can start a course of possible. Usually this is sterile and we don't start antibiotic. We could start some nasal spray and as well as antihistamine. We see how is it and do an endoscopy and rule out the tumor behind the nose. So why the patients also present with all this facial numbness and as well as diplopia? Because this nasopharyngeal carcinoma, which is lies just below the cavernous sinus, which is also below this sphenoid sinus, and it can spread up. So the first nerve that involved is the maxillary divisions of the trigeminal nerves, which can give numbness on the cheek and as well as ophthalmic divisions of the trigeminal nerves. But most of the patients will not come to you with this kind of subtle symptoms. They will just ignore it. So the next cranial nerves that involved will be the abducen nerve, which is the 6 nerves here. And these 6 nerves will cause a diplopia. So they will see double visions on the lateral gaze. So this is the divisions that you can check on the patients, the soft touch and also the point, sharp touch to pin the prick test to check how's the integrity of these nerves. So this is how it shows that the patients have a 6 nerve palsy. So sorry. So this is a video showing that the patient have a right-sided 6 nerve palsy. When the patient looking onto his right side, the patient could not actually, the eyeball is not moving towards the right side. Let me try to play again. Okay. So when the patient looking to the left side, there's no diplopia, there's no double vision. When the patient looking onto the right side, there's double visions. So in this kind of patient, they will refer to the ophthalm team first, and later on they'll refer to the ENT team to rule out the NPC. Okay, so looking at the signs and symptoms, nasopharyngeal carcinoma, which is behind the nose, has a way to spread towards the other spaces. So the eustachian tubes could cause you a serious otitis media, which is also called the middle ear effusion. And if it is spread to the nose and the orbits, then the patient will have proptosis, nasal obstructions, nose bleeding. And if it goes to the skull base, it's involved the foramen lacerum and overlay. The patient will have some cranial nerve palsies, cranial nerve 3, 4, 6, 5, and 6. And the other lower facial nerve palsy, if spreads to parapharyngeal spaces. And sometimes trismus, if it's quite extensive, which involve the pterygoid muscles. And the retropharyngeal nodes is the first ankylons that causing a neck pain, as well as a retroorbital pain or the headache inside the head. Cervical lymph nodes could be palpable from the neck as well. So you could check, mostly they will present with a level 2 and level 5. So this is a level of lymph nodes. So you could check, most of the time they present with a level 2 lymph nodes, which is just below your ear, and also level 5, which is just behind your sternocleidomastoid mastoid muscles. So interestingly, we actually look into a lot of risk factors of the nasopharyngeal carcinoma. So we will not pinpoint which is the cause of it, but we call it as a risk factors because there's multiple, it can be multiple risk factors, but it's not one of the causal and effect relationship. So the ethnicity, especially the Chinese, which is from the southern part of the China, the Guangdong, Guangxi province, which found to have carry on some genetics which is susceptible to nasopharyngeal carcinoma, and the natives of Sabah and Sarawak. And the gender, male is predominant, probably because of the factors of most male are smokers, but I see there's a dropping of the prevalence of smokings in Malaysia, as there's a lot of activities we trying to encourage people to stop smoking and prevent not to gauge on this smoking habit. And family history of NPC, how's the lifestyle, your food diets and the environment factors, tobacco, smoking, alcohol, consumption. Interestingly, the consumptions of the salted fish is also one of the risk factors, as one of the study which found in the Hong Kong fishing, the one that stays on the boats in the olden Hong Kong's days, they actually found that the early exposures of salted fish in their life can has higher risk of getting NPC. But interestingly, they also found that the amount is not justified to the risk factors, but the early age. And do not forget that our ikan bilis is also one of the category of salted fish. So try not to introduce any of the salted fish to your children. And exposure to the domestic wood cooking fires, which I believe that many of us in this now modern society are not using wood cooking fires anymore, but you'll be surprised that you'll see these wood cooking fires are still happening in the indigenous place in some part of Malaysia, such as Sabah and Sarawak. And the exposures of the occupational solvents and the wood dust industry exposure. So looking at this diagram, I would say that the EBV virus is currently now has been greatly studied, and it is a multifactorial that causing all the NPC. So there's a genetic, when the EBV virus has been exposed to the nasopharyngeal epithelium, it combined with the genetic susceptibility, like the Chinese carrying on the genes in their body, and they will stay dormant in the epitheliums of the nasopharynx. And later on, when the patients have reactivations and colonal clonal expansions at certain age and with some immunosuppressants environment, then the NPCs will come into place. So what is the diagnostic investigations in our country nowadays? Of course, this is the nasopharyngeal nasoendoscopy that we do is our bread and butter in our clinic, in ENT clinic. So we introduce, this is a rigid scopes that we scope into the nose and looking behind the nose, the nasopharynx, and it will show us this is an ulcerative mass behind the nose, the nasopharynx area, and this is a proliferative fungating mass at the nasopharynx. And the commonest sites of the NPC will be the fossa of Rosenmüller. So if you see my pointer here, so this is the fossa of Rosenmüller, okay? Then this is the area that with the ulceration. So this is a flexible nasoendoscopy, which is a bit more comfortable compared to the rigid endoscope. So this is what I do in clinic. Let me show you. So this is how I pack the nose before I start to do my biopsy behind the nose. So this is our patient suffering for a mass behind the nose. We are not very sure if it's NPC or it could probably a lymphoma, which and the second. Okay. So when I introduce my scopes into the nose, so this is the middle turbinates and I'm going to the back. There's a lot of blood stained mucus here. And this is the mass, if you can see. I'm touching the mass and it's actually causing easily bleed at the inferior part. Okay, so this is the features of a tumor of the nasopharynx. So now the third video showing that how I perform nasopharyngeal biopsy using a Blakesley forceps that you can see that I'm grabbing a sample and send it for the HB evaluation. So basically we need the specimens to be sent and to confirm it under the microscope and staining to make sure it is an NPC. And the differences could be, I have seen patients with a similar presentation for NPC and presented which come back with a diagnosis as TB, nasopharynx TB, and as well as the other commonest one would be lymphoma. Right. So recently, there's a lot of GPs out there and there's a lot of pathological labs that are introducing blood screening for NPC. However, in our ENT practice, we still not encouraged to do so because it's not cost effective and the sensitivity and specificity is still not giving us a very good sensitivity and specificity. So we only target certain populations. So this is what I have studied through the meta-analysis. So they target the population for NPC screening would be only for the male patients who is at the range of 30 to 69 years old, which stays in endemic area. I could say Malaysia is one of the endemic area for NPC occurrence. And also the middle-aged adults with a positive family history of NPC, or this patient has been screened for any of the GPs and followed by another 5 years later screening. So the screening choices, the blood screening choices modality, I think is quite common in in Malaysia, the GPs will send for this antibody, EBV antibody, IgA. But in the literature, it will ask for a combined IgA and as well as VCA to be sent if it is both positive, and you should actually refer this patient for the for ENT for nasoendoscopy screening. So the other more sensitive and specific, which also giving a good positive predictive value, will be the plasma EBV DNA by the PCR test. However, this test is actually very, very expensive. I think it is not easy to find, and is a few hundred ringgits, and it is not common in our market yet. So what we do if the blood screening is positive, so we'll do a nasoendoscopy with a targeted biopsy. If we see something suspicious, then we'll do a biopsy of the nasopharynx. And if we will discuss with the patient if they keen to go for MRI screening, because it is more sensitive and more specific in diagnosing the early tumor, such as the stage 1, stage 2 local tumor. MRI could play a very important role. However, MRI is extremely expensive. It could cost up to 2,000 ringgit. Okay, so if let's say the nasoendoscope does not show any positive results, then we'll follow up with another screening with a nasoendoscope in 6 months, every 6 months, until 5 years. Then we repeat another blood screening. Okay, so this is study protocols studies that has been done, which shows the sensitive and specificities that using the EBV IgA and as well as the plasma EBV DNA. Apparently, the yield for this EBV DNA is actually higher in doing the screening. It's still the issues that we are talking about is the money. Okay, and what about endoscope and also MRI? Of course, the MRI giving us a very good sensitivity and specificity. But if you see something from the endoscope and you do a biopsy, it will of course give you the diagnostic value of it. But MRI is just showing there's a mass on it, and you still have to go through the nasoendoscope for the patient. So this is algorithms that how you could go along with the blood screening for the EBV screening in these NPC groups, high-risk NPC patient. So you could actually, in GPs, you could actually order a serum VCA. Remember, male patients, 30 to 60 years old, predominantly with a family history of NPC, and also staying in an endemic area. So I could say rarely, I hardly see any Indians get NPC. So you could screen the Chinese and the Malay community, and also the Sabah, the natives of Sabah and Sarawak. So if it is a positive screening results, please do not hesitate and refer to the ENT surgeons for nasoendoscopy, and we will advise the patients if they're willing to pay some money to go through the MRI, and we will follow up the patient 6 monthly. If there's a lesion found, then we'll continue with the diagnosis of NPC and subsequently the treatment of NPC. So how do you manage an NPC patient? First, of course, get a history, complete history taking. If the patients, you know that the patient has exposures to modifiable risk factors such as smoking, alcohol, or occupational exposure, you could actually advise the patient try to avoid it for further to actually prevent them for further damage of the mucosa and epithelium, which could also give you a bad results from the radiation therapy, and it also cause a recurrence in NPC later on if they continue to stick on the bad habits. So the other thing is a complete physical examinations and write down your signs and symptoms that the patient's having, and it could give us a clinical staging for the patients. If the patients have the cranial nerve involvement, it could probably is a T4 tumor. So it could come with a poor prognosis for the patients with a neck mass as well. So refer us with the nasopharyngeal examinations, and the biopsy could be done. And sometimes we'll do the FNAC of the lymph nodes, but it's not mandatory. If we could yield a tumor HPE which shows positive in the specimen, we will not proceed with FNAC. If there's no tumor and patient present with lymph nodes, then we'll proceed with the FNAC by no doubt. So baseline investigation, if in futures that you want to send this patient for oncological treatment, so you could actually order FBC, renal profile, random blood sugar, liver function test, chest X-ray, and also echocardiogram. So some of the oncologists also will ask for the TB workup as well, because TB is so common in Malaysia. They will ask to start the treatment for TB first, and only they will proceed for the oncological treatment of it. And depends on the patient financial background. So you can actually ask for MRI for better and precise staging, or CT scan with contrast for the skull base up to the thorax. The upper abdomen will be enough for our staging. The best is still the PET scan for staging. And we also refer for this kind of patient for dental assessment. If they have a rotten tooth, we need to take it out because we need to expose the patient for radiation. If there's an ongoing infection of the tooth, it will cause an osteoradionecrosis in future, and it will cause a lot of morbidity for this patient. And also assess the nutritional value for this patient before you refer this patient to the oncological treatment. So this is a contrast enhanced CT scan for NPC patient. You could see that on the left side, let me do the laser pointing. So this is the left side of the nasopharynx. You could see there's a mass that invading into the prevertebral fascia and prevertebral muscles, and also laterally it goes to the the parapharyngeal spaces. And also the patient also presented with lymph nodes, cervical lymph nodes. So this is a cervical lymph nodes, right? So looking at this PET scan, so PET scan can actually giving us a better yield for higher sensitivity and specificity for staging purposes, especially for those who has been underwent the CCRT, the radiotherapy and chemotherapy for this patient, and we want to restage. PET CT is still the gold standard for it, and sometimes we also, because it's not every center have PET CT scan, so we could also subject the patients for another CT staging. So how do we stage NPC? Looking at this TNM staging with the AJCC classification 8 version. So the primary tumor for T1 tumor, which is confined to the nasopharynx, which extends to the oropharynx, so going down to the oropharynx and going anteriorly to the nasal cavity, but without the involvement of the parapharyngeal involvement. So if you see a mass that go laterally to the parapharyngeal spaces, then it could be a T2, which is the soft tissue involvement. When you see a bony erosion of the adjacent structure, it could be a T3. And if there's an intracranial extensions or cranial nerves involvements, orbits, parotid gland, or extensive soft tissue infiltration, hypopharynx, this could be a T4 tumor. So, and the end staging will be N1, N2 bilateral. N1 is unilateral, N2 is bilateral with the size of more than the size is lesser than 6, and it is above the cricoid cartilage. And N3 will be unilateral or bilateral, but the tumor is 6 centimeter in the greatest dimension, or it is below it. The tumor, the neck mass is actually the cervical neck nodes is below the cricoid cartilage. And last but not least, the metastasis. M1 will be the distant metastasis. So there's also grading for the nasopharyngeal carcinoma, the keratinizing SCC, the non-keratinizing but differentiated, and the non-keratinizing undifferentiated. So what happens in Malaysia that most smokers has a keratinizing squamous cell carcinoma, and this is has been proven less radiosensitive. However, there's more patients in our community has a non-keratinizing squamous cell carcinoma, the undifferentiated type, which is also associated with the EBV virus. And they are actually more radiosensitive for the oncological treatment. So this is also the stagings that showing the proposed 8th addition. The T2 involvement is the parapharyngeal spaces. And if this is a T4 tumor, it will go more laterally. And this is the caudal border of the cricoid cartilage. Remember, in N3 patient, the neck nodes, which is below this cricoid cartilage, we'll consider the patient has a poorer prognosis with an N3 staging. So what is the main management and treatment for NPC? Until up to the current updated management, we will still, the primary treatment for all the stage of NPC is still radiotherapy and chemotherapy. Why it is not common to have a surgical therapy? Because it is quite an extensive surgery and the outcome is not as good as the radiotherapy and chemotherapy. So it is very uncommon to see any surgical as a primary treatment for NPC in our society nowadays. So this is the proposed management from our CPG. So for stage 1 disease, we can actually subject the patient for definitive radiotherapy only. And this is a total dose that we give at the primary site. And sometimes we'll give a prophylactic dose to the neck for prophylaxis. And IMRT is currently arising in Malaysia, and more centers we have IMRT. We also could recommend them if depends on the availability of the facility because of the minimized dose to the critical structures. I'll explain a bit more about how they do it. Basically, I'm not the best person to talk about radiotherapy and chemotherapy. Probably the next time the society can invite the oncologists to talk more about the radio and also chemotherapy in future. So for stage 2, 3, and 4, 4A and 4B, it is still a good prognosis. So sometimes we'll subject this, most of the time we'll subject this patient for a concurrent chemoradiotherapy, and do not be surprised that sometimes the oncologist will prescribe a neoadjuvant chemotherapy for the waiting list for the radiotherapy to go together with the concurrent chemotherapy is the waiting list is quite long, so they will subject the patient for neoadjuvant chemotherapy first, especially in our government setting, so that at least we could give something to the patient to control the disease. And IMRT also recommended for this patient. Of course, the first line will be the cisplatin. And for the stage 4C with a distant metastasis, we will consider palliative chemotherapy, clinical trials, and palliative send for palliative care. And the prognosis sometimes is pretty poor. So try to catch your patient before they have distant metastasis and try to persuade them for the radio and chemotherapy because the outcome is pretty good at the early stage. So this is basically what is the treatment options for the nasopharyngeal carcinoma: surgery, chemotherapy, radiotherapy, immunotherapy, which is a new rising topic, therapy. So what is the difference between the conventional radiotherapy and the 3D conformer, which is more common nowadays compared to the olden days? Because the exposure to the tumor site and also the adjacent site of the conventional radiotherapy is higher compared to the 3D conformer because they are targeting. So the adjacent structure will have less exposure for the radiation. So I will talk about a bit of the complications of radiotherapy later. And look at the recent one, the proton beam therapy, which is also available in many of the advanced countries. I think in Malaysia, there's a few private settings is trying to get in this proton beam therapy. So the conformal one will be like this, the exposures of the radiation is consistent throughout the one that shine from the directions. Okay, and the targeted site will be here, but the adjacent structure will also expose to a certain level of radiation. Whereas the IMRT, the intensity modulated, will given in multi-directional with a lower dose to the adjacent structure. So the toxicity of the adjacent structures of the radiation dose will be less, and patient could suffer least of the radiation complication. And the conventional proton beam, which I heard Dato' Lee Chung Wei is using this in Taiwan, if I'm not mistaken. The adjacent structures has a very, very least kind of radiation exposure. So the side effects will be less. However, of course, it's still talking about a price. Is like a Kancher and a Mercedes, comparison. So that's how is it. So this is the mask before we refer the patients to oncology. They will be given a date to do the mask, to do the site, and also to draw which is the way which is the targeted area, so that they can target to the sites of the tumor. So this is how they look like. And don't be surprised that some of your patients coming back from overseas, I have seen patients coming back from China with a history of brachytherapy. You could probably, what's this brachytherapy? Is actually they put in some isotope sensitive kind of radiation particles into the sites of the tumor and give shines of the radiation to the targeted area. So this is how they do. They put the patient under general anesthesia and implant in the material into this area, and they will shine radiation to the radiation into this area and cause the tumor shrinkage. So sometimes the implant they will not remove and it will still persistent in this area, and you could actually catch this patient up by doing a X-ray or sometimes a CT scan. You can see some seedlings and some metals behind the nose. Please do not be surprised. It could be because of the brachytherapy. Honestly, we are not very familiar with this, and I have never seen this before, this kind of treatment before in my practice. So we are taught, if your patient has been subjected to the radiation, they will have a acute toxicity. They will have lethargy, radiation dermatitis, mucositis, dysphagia, taste change, nausea and vomiting, and hematological toxicity. Basically, if you see a patient in your setting, you could actually prescribe them for symptomatic therapy. And sometimes they present late into your setting. So they will have temporal lobe injuries, cranial nerve palsies, Lemaitre syndrome, and also non-neurological complications such as tinnitus, hearing loss, otorrhea, trismus, dysphagia, and some fibrosis of the neck, the subcutaneous fibrosis, which cause them to have limited neck range of motion, and endocrinopathy with a primary hypothyroidism or hypopituitarism, xerostomia, and second cancer with a radiation within the radiotherapy fields. So the World Health Organizations have the oral toxicity scales, which shows that this patient after radiation, they will have soreness, erythematous of the mucosa of the oral pharynx, and grade 2 will show ulcers, and patient has swallowing difficulties for solid food. And the severe mucositis, you should actually prescribe them with some analgesia or some anti-inflammatories, which they will present with ulcers with extensive erythema, and patient cannot swallow food. If patient cannot swallow food and you think the patient is very cachextic, please do not hesitate to start a nasopharyngeal tube and just give them more nutrition, because that is the most important time that you should not put them into immunocompromised states, so that they can regain their body general well-being of their body. So the other thing will be the grade 4, the mucositis, to the extent the elementary is not possible. Then this kind of patient you could consider to refer to the ENT team or the dental team as well. So what you could actually prescribe for them. So in the past, we have magic mouthwash. In our pharmacy, we actually try to make our own magic mouthwash, which includes the Benadryl, the diphenhydramine, and mixing with the Melox, which is also the aluminum hydroxide and also magnesium hydroxide, and as well as viscous lidocaine. In Malaysia, we call lignocaine. So the other thing, if you think it is very troublesome that you want to mix yourself in your clinic, then you could probably ask the patient, or you can just get in some Oral 7 for moisturizing mouthwash, which has ingredients to moisture with hyaluronic acids as the active ingredient, or Afzan, and as well as the anti-inflammatory properties. Throat spray will be the benzidamine, the diflum. They have different forms of it. They have syrups, they have the lozenges, and also a throat spray. And this is a lignocaine, which has the 2% of the lignocaine, which you can ask the patient to rinse it before they start eating. And Orodex is also the chlorhexidine, to make sure the patient is free of bacteria, because when you have a mucositis, the patient has very high risk of secondary bacterial infection. So what you could advise the patient, if you do not have any of all these things, is just ask the patient to rinse the mouth with salt water or sodium bicarb, which is our baking soda. Just put a small teaspoon of baking soda or your salt, home salt, and put it in a glass of water and rinse the mouth after every time they eat. And additionally, you can ask the patient to buy all this kind of medicine to help to reduce the pain. And last but not least, to prescribe them some analgesia so that they can take their food. Okay. So what happened if after the radiotherapy, the patient present you with a prurient ear discharge, and you see this, which there's a lot of pus discharge coming out from the external ear, and sometimes you'll see a perforations. This is an active middle ear infection. So you could just clean up the ear and ask the patient, you can prescribe the patient with some ear drops like ofloxacin ear drops to get rid of the secondary bacterial infection. Or sometimes the patient will still says that they will have hearing loss, and you look into it, oh, there's still this middle ear effusion. And in the olden days, the practice is they will refer to the ENT and will put a grommet. So this is a grommet of plastic tubes that we actually draining out these fluids out of the middle ear so the patient could actually hear better. But we found that most of these NPC patients, when we do this grommet insertion, they will prone to have ear discharge and middle ear infection. So basically in my setting and within my practice nowadays, I do not actually prescribe a patient for grommet anymore, but I will subject the patient for a hearing aid. So the next commonest side effects for radiotherapy for NPC will be the dermatitis for the neck. So what you could do is you can just prescribe them analgesia and as well as the emollient and also some the moisturizer to fasten the recovery of the neck. And do not forget, if they could try to make sure they are moving the neck. If not, they will end up with fibrosis, neck stiffness, torticollis, and there will be difficulty in moving their neck in future. So start the physiotherapy as soon as possible to prevent the contracture happen. All right. So some patients will also present with trismus. So what is trismus is the inability for them to fully open their mouth. So if they have this limitation, it will actually difficult. It will be a problem in future if you want to intubate a patient through the mouth with a oropharyngeal ETT. And this will also cause them to have difficult in chewing. So what we do is we will teach them how to do a physiotherapy for the mouth opening. So what you can do is you just get all this spatula, the wooden spatula, and you add on in between the wooden spatula to open up the mouth. And you could actually push the wooden spatula up down, so that it can slowly open up the mouth. So do this physiotherapy as soon as possible to prevent the late complications. So what else? So when we do expose this patient with radiation at the posterior part of our nose, which is also very near to the pituitary gland. So they will present with a panhypopituitarism and as well as secondary hypothyroidisms. Sometimes if we give the radiation at the neck level, and they will have primary hypothyroidism. And I have experienced that after we try to open up the neck for some reason for the patient's post-radiotherapy, the thyroid gland become very rubbery and is very fibrotic. So it's non-function anymore. So annually, we will check for the thyroid function test for this patient, and do not forget the renal profile for this patient, which can also shows that will be high sodium or sometimes low sodium in this kind of case. So do not forget to counsel your patients if they will have a problem in futures for growth, and as well to get pregnant or to get babies in future after the radiation, because we find that NPC could actually happens in very young patient. I have seen a patient with 9 years old getting NPC, and we have to send the patient for radiation at this early age, and they will suffer from all these radiation complications for their whole life. Okay. So what about the chemotherapy? So the cisplatin is the one that commonly prescribed, and the other one is a fluorouracil and carboplatin. So what cisplatin will give a common side effect will be nausea, vomiting. You could actually prescribe a patient with some antiemetics for the patient and also hydrate back the patient. Myelosuppression, do a regular FBC check, and also renal toxicity. So I say, like, you should screen your patient with for the renal profile and electrolytes as well. Auditory, so that's why you screen the patient before and after the radiation therapy. And if the patient has actually complained of hearing loss. And for uracil, the patient will have diarrhea, stomatitis. So it's all symptomatic treatment that you could actually prescribe for the patient. And there's a special precautions for patient if they have a history of heart diseases. Then you should tell them, if you have a heart disease, maybe they will prescribe another kind of chemotherapy and docetaxel as well. So you could check these common side effects from the CPG. I'm not going for very detail in this presentation. So if you see a patient with a post CCRT, how do you actually examine the patient in your setting? If you are ENT surgeons, of course, you can do a nasoendoscopy and also a neck examination, palpate the neck, and as well to do a cranial nerve examination, send the blood investigation for the patient, and also do check for the complications for the CCRT as well. And the first year, you could monitor the patient with very close monitoring up to 1 to 2 months. And second year, you could gap a bit, and third year could goes up to 6 months, and so on. So it will be more common to see at the first year. So if you see any signs or symptoms of recurrence, you should actually refer back the patient to the ENT and talk to us or the oncologist that we might need to do further investigation and staging for the patient for recurrence, because the recurrence in NPC is not uncommon anyway. So what happens if we see there's a persistent or recurrence NPC? For the local disease, which is a recurrence, sorry, let's go to the first thing first. So we have to restage the disease. So first thing is we need to know it is a local disease recurrence or regional disease recurrence on the neck, or a distant disease. So what we do is, if we see a local disease recurrence, we should repeat the biopsy if clinical indicated. And if we see there's a neck nodes, we could actually repeat another FNAC for the patient, or do incision biopsy or excisional biopsy, which is not commonly done. We will still rely on the FNAC because it will breach the skin. And we will restage the patient using the CT scan or the PET scan or MRI, depends on the availability of the facility. So if it is a local disease which recurs, the tumor recurs in behind the nose, we usually will not subject the patient back for radiation, radiotherapy anymore, because of the maximum dosage of the toxicity, radiation toxicity for the patient. The more radiation you given for the patient, the more side effects and the higher risk of side effects could be happen. especially this nasopharynx is a place which is very near to the spinal cord, and they will have the Lemaitre syndrome, which will cause body weakness, lower body weakness for them. So we will usually not subject patient for radiotherapy. However, there's many years ago, we did some brachytherapy in some of the places in Malaysia, and in the end, we found that the nasopharyngectomy has a better outcome, and it is more doable, and the complications of the nasopharyngectomy is not as high. And the other thing, if it's only occurs on the neck, the recurrence on the neck, and we will do a neck dissection for the patient so that we will not re-expose the patient for the radiation. So re-radiation and chemotherapy will be the second option. So, but if the patient has a distant disease, then it will be another story. So we will actually subject this patient for palliative chemotherapy, because the survival outcome is no longer as good for any surgical intervention. All right. So let me go back to some. So this is the nasopharyngectomy that we do. We'll do a scope through the nose, and we'll put in our devices and excise the mucosa behind the nose, and it will be exposed like this, or we'll put up a flap towards the area. If we put a flap on this area, and we have to subject the patient for imaging, because the tumor recurrence can be behind the flap. So sometimes just by endoscope will not be enough for us to monitor the patient, and we might need imaging surveillance for this patient. So for neck, we have to, if there's a recurrence neck nodes, at least we have to do a modified radical neck dissection. So what is modified radical neck dissection is that we take up all the lymph nodes from level 1 to level 5. And also we'll consider if there's a lymph nodes which is very sticky and adhered to the vessels and the muscles, and as well as the accessory nerves. So we will consider to sacrifice these structures in our neck dissection. So this is post neck dissection scar. Do not be scared when you see this. Just try to palpate. Sometimes by palpation for this kind of patient, for a recurrence is not easy. We will do at least ultrasound to check if there's any small lymph nodes recurrence on this area. Okay, so this is just now the slides that I talked about. So after the recurrence management, this is again our follow-up and surveillance. And so that's it, my presentation. So
thank you so much, Ms. Teh, for that wonderful presentation about nasopharyngeal carcinoma. I know I learned a lot of new things, and especially the staging and the grading part was very interesting, and those videos were amazing. Ms. Teh, can I ask you, do we know like what stage specifically Dato' Lee Chong Wei was? Like,
I'm not very sure about it. I think it's supposed to be private and confidential. I'm not very sure about it because I'm not a big fan of badminton fan. I'm very sorry about it. Yeah.
All the news that came out as he went for proton therapy, but never lost his hair. So should be quite early, I guess. Yeah.
I guess it's a higher grade because if proton therapy, if he's using proton therapy together with some chemotherapy, I can see still there's some fibrosis at that region as well. The neck fibrosis, I guess is not T1 anymore. It's something like higher than T1 because they could probably give radiation to the neck, because if you realize that, if you can see he still has a bit of neck stiffness, right? And some scarrings on the neck. So probably I think is more than a T1, and there will be a neck swelling there previously. Yeah.
Thanks. And thank you for bringing up proton therapy. For now, proton therapy is only available in Singapore, Thailand, Taiwan, like in our
Taiwan,
region.
China, right?
And
Yeah.
I spoke to a clinical oncologist the other day. One proton therapy, so it's cost effectiveness is not there. One proton therapy machine
Mhm.
will cost up to, is equivalent to 10 radiotherapy machines.
Ah, yeah,
Okay.
it's very, very
Yeah.
expensive. So in Malaysia, in the government setting, because I'm working in the government setting, so the best we can offer is IMRT nowadays. So we try to subject all of our patients, we try to subject all of our patients to IMRT, but it is impossible because there's too many patients having this cancer and everyone waiting for the IMRT to get this treatment. But unfortunately, the patient load is too much and we cannot cope with it. Hopefully that in future, there's more center will equip with this IMRT. At least the IMRT could help in our patients in future, and I will not see so much of a complication from all this from the side effects of radiation therapy anymore.
So, Ms. Teh, so there's one question from YouTube actually from a Dr. Rudresh. He's actually asking, is NPC more of a genetic problem or an environmental problem? Which is the most surprising risk factor for NPC? Because you gave a list of like the non-modifiable and modifiable, but like is the genetic factor the more important one or the lifestyle exposure factor the more important one?
Yes, I think nowadays everything is about gene, but don't forget that the environment is also changing our gene, right? So that's also, I will not say which is more superior than the other one, but I believe that the genetic is one of the main things nowadays that we are talking about, and it carries, if you see the prevalence among our community, you hardly see any Indians who get NPC, really. Hardly see any of the Indians who get, unless the one that who is the Chindian. I've seen Chindian who get. So you see that the genetic has been so strongly imprinted in our body and carry such a major determinants in predicting our risk factors for NPC nowadays. So if you ask me about it, I will say that the genetic play a major role, but for my experience, I will not say which is more superior than the other one, but of course, genetic plays a major role. And do not forget, our environmental factor will also change our genetic over the time, right?
So again, the adage is true. Malaysian Chinese middle man coming with a neck mass, you have to think of nasopharyngeal carcinoma. Right? I mean, the adage is still true.
Yes.
So we have a question from Dr. Noor Helinda from Docuity. Yeah, so she's asking, as epistaxis contributes to 80% of the symptoms in suspecting NPC, how can we differentiate the symptoms of hot climate or NPC in terms of duration or maybe the amount of blood?
Okay, there's a lot of patients presented with epistaxis, right? So what I do is, I know there's a lot of people having just blood streaks, hot weather. But for our practice, we do not say that because of hot weather that causing epistaxis. When you have epistaxis with all these risk factors, do not hesitate just to do a nasoendoscope. Just do an nasoendoscope. There's no harm to do it. I know there's a lot of GPs nowadays, they are trained, they are medical officers previously from our departments, and they go out and open a GPs and they do offer nasoendoscope. Actually, I have no objections with all these screenings in these GPs lah. But it's good just to do a screening. Why not? I mean, epistaxis with strong risk factors, I think you should just do a scope. Yeah, do not just overlook these symptoms because it's just behind the nose and we have no idea what's happening behind the nose. And there's a lot of ways that we can deal with recurrence epistaxis. Okay, if let's say the patient come with you one time, you could probably just ignore the one time with a very subtle, very minimal kind of blood streaks epistaxis. But when the patient come with torrential bleeding, then you should think of something else. It might not be NPC, but it can be other things, right? So the other thing is the patient comes with recurrence of the epistaxis, you should also consider NPC could be one of the diagnoses. Okay, so in conclusion, what I will say is, if you have a patient with the risk factors that I mentioned just now, just refer the patient for nasoendoscope. Okay, secondly, if you have a patient with recurrence, very massive bleeding, nose bleeding, also refer to do a nasoendoscope. If not, if you're interested, if you are in a GP setting, you can also check on the patient's EBVs. You can do the EBV screening, okay? But it's still not a practice yet. But if it's positive, you could actually ask the patients to come to the ENT department and ask us to do a NPC screening for the patient. Yeah, but I think epistaxis, the cause of epistaxis is not only because of NPC. So just by using the blood screening for EBV is not sufficient enough, actually. It's not sufficient enough to justify what's happening behind the nose. So I will still say, just refer us to do a nasoendoscope, right?
Well, Dr. Noor Helinda, I hope that answers your question. Thank you, Miss Day, for answering that. Just got a few more questions actually from YouTube side. One is actually this. What are the challenges in managing nasopharyngeal cancer, both from like a patient perspective, healthcare provider perspective? Meaning, is it like education, is it a screening, or is it the cost of investigations, management? Where do you see the pitfalls of detecting nasopharyngeal cancer?
You mean detecting or receiving the treatment?
So the whole cancer continuum, when you talk about like prevention.
I think I think it will be the late presentation. So most of the time that the patients will come to us with a very late presentation when they have a big mass on the neck or very bad kind of foul smelling discharge from the nose, or they have a squint, diplopia, the blurring vision and double visions of the eye. They will not come with cheeks numbness, or just rhinorrhea, but they will come with some things that alarm them and very apparent on their face and very disfigured and very bothering for their daily activities. Then they'll come to us. So when they come to us, they presented with quite a late stage. So that's why NPC awareness is so important, because we want to tell the communities that this NPC is just behind the nose, that most of our patients has no idea what's behind the nose, and it is so difficult to pick up at T1, T2 presentation. If you miss the early treatment, the outcome, of course, will be poorer towards the later stage, right? So the other thing is, I think our community, I hope that the community nowadays is getting more educated that cancer is not a sentence to death, right? Cancer is not a sentence to death. So you should actually think that cancer could actually be cured, especially at the early stage. So screen them. Do refer them to the experts as soon as possible before it getting worse. So if like a patient with a neck mass that you treat as a infection, lymphadenitis, or neck abscess, and it is not resolved despite you give a course of antibiotics, do not hesitate to refer us as soon as possible. Put in a scope to check in the nose, right? So that's what I want to say. Do I answer your question?
I think that definitely answered the viewers' question from YouTube. Okay, so I think we have two more questions, and we can wrap up already. The next question is from Dr. Swaren. He's asking, There's a type of growth, reticulosarcoma, mixed salivary gland. Does that come under the heading of NPC? So that's the first question. He gave a few questions, but all one together. The next
Okay.
one, is it usual to develop root pains without radiological changes in the NPC?
Okay, can I answer the first question first? Because it gets very complicated. I cannot focus on it. So, what is it, the sarcoma?
So there's the type of growth like reticulosarcoma, mixed salivary glands. Does that come under the heading of NPC?
Oh, no, it is not NPC. So NPC is actually squamous cell carcinoma. So with the salivary gland, of course, in the behind the nose, there's a mucosa, right? So we also have some salivary glands, salivary glands at the mucosa of the head and neck region. Okay, so this kind of mucosa is quite common to have salivary gland tumor at the anywhere at the head and neck, the mucosa of the head and neck region, other than squamous cell carcinoma. But it stands a very minority of the our patients. So what we do for this kind of patient is always come with surgery first. Or we can consider, we always talk to the oncology, is it feasible to give a primary radiotherapy? Because it's always easy to do a surgery before any radiotherapy, because it's easier for us to cut on a fresh tissue rather than a fibrotic tissue and all these things. So most of the time we'll consider if this kind of case is can be surgically excised first or not, or we should subject this kind of patient for radiation therapy. And remember that not all types of cancer is radiosensitive. So it depends on the cell lining and as well as the types of cancer. So we always discuss with the oncologist and we'll come up with the best interest for the patient. Okay, I hope I answered the first question. Second question?
So the second one is it usual to develop root pain without radiological changes in NPC?
Root pain?
Nerve root pains.
Without radiological changes. Yeah. So I've seen a lot of patients with some neck pains without fibrosis and all these things because of the radiation exposure towards the peripheral nerves. So sometimes you have neuropathy and you could give some mycobalamins or B12, which could improve. And some people say that acupuncture nowadays is available so commonly in Malaysia and has been proven it helps. I'm not trying to promote them, but it also one of the options that you could actually offer for the patient. Or you can refer to our physiotherapy. They have a lot of ways that they can do. They can have a electro stimulations therapy and things like that, which can actually elevate the pains and the numbness and things like that. So, but always remember, what we do as a doctor is we should relieve pain for cancer patient. Do not hesitate to give analgesia for cancer patient because they are suffering. So we want to improve their life, the quality of life of cancer patient. That's the most humane things I think ever as a doctor that we can do is just to prescribe analgesia and try to convince our patient, telling them that analgesia is okay, not that they're going to kill you or, I think a lot of patients in our society is still very stigma on analgesia. So if a good doctors know what kind of analgesia is supposed to be given to the patient, then there will be no problem. Convince your patient. The other thing is if your patients have bone pain, and what I have learned throughout the years is if your patient have bone pains and also neuropathic pain, don't hesitate to start gabapentin, amitriptyline, they are actually a good drugs for patient, but just that you need to know how to prescribe and how to monitor your patient. Okay.
So the final question from Dr. Swaran is this: is bleeding on the eustachian catheterization a sign of utmost importance in NPC?
What does it mean again? Sorry.
asking, is bleeding on eustachian catheterization a sign of utmost importance in NPC? I believe he's talking about grommet insertion. Means if you grommet and got a lot of bleeding, I used to suspect NPC.
Grommet bleeding will cause NPC.
Yeah, so
Okay, that's the two entity of it. I think people are a bit more I think they're confused. So the grommet insertion that we put a grommet be on the eardrums, right? The tympanic membrane is just to relieve the fluids from the middle ear so that the patient doesn't have a bone conduction hearing loss. So it's improved for the hearing. Catheterizations of ET, you mean we do have balloon dilatation nowadays through the nose and go to behind the nose and through the eustachian tube and we dilate it. However, there are studies that shows ambiguous kind of results because this kind of NPC patient, right, when they exposed to radiation therapy, they have a lot of bad fibrosis and it has been stagnant. You know, the structure has been so fibrotic that even though you put a balloon to dilate it, it doesn't give you a good outcome. So I'm not a believer in doing balloon dilatations post radiotherapy. But you could try, you could try, but I will say the outcome is quite guarded. Okay.
So Dr. Soren, I hope that answers your question. I think there's no more questions already. So Ms. Teh, thank you so much for your time here on Dr. T, and on behalf of NCSM, thank you so much for helping us give awareness to our healthcare professionals about nasopharyngeal carcinoma. I believe not only
Thanks
for
for having
myself, but yeah, I think
Thanks
it's
for
very
having me.
enlightening.
Thanks for
All right.
having me here. I hope that more people will get awareness of NPC and refer the patients that having all these symptoms to us as soon as possible so that we can improve their outcome by giving them early treatment for NPC. Remember, cancer is not the death sentence. There's always a cure for it if it doesn't progress into the stage 4C level. So give a chance for a patient, give a chance to yourself not to, not to miss this diagnosis, right? See you guys. Thank you. Thank you very much.
Bye,
Bye.
everyone.